Now, my next task is to introduce the co-chair of this meeting, and in fact, the individual who's done the lion's share of the work. And it's been a great pleasure to work with Ami throughout all of this. Ami Sperber is from Ben Gurion University of the Negev, Beersheba in Israel. He is widely known for the work that he's done in comparative studies in functional gastrointestinal disorders, and has made major contributions to cultural and socioeconomic aspects of irritable bowel syndrome. And I would like Ami now to come forward and to discuss the background to this particular meeting.
Just 1 second to switch gears here. Okay, well, it's an honor and a pleasure to introduce this meeting and, so to speak, to set up the stage for the fantastic faculty of speakers that I think we have for the meeting. So I will make a quick introduction. Now, my feeling is, and I really do not have the data to substantiate this, that we are not aware enough of the cultural factors and their association with health. That lack of awareness can have negative effects both in terms of clinical practice and in terms of research. Clinical practice, to simplify things, would lead to poor health outcomes, and in research can lead to methodological problems with possibly suspect results of studies which we're not actually aware of because we're not aware of the problems that we face. So, in a way, the rationale and the goals of this meeting are to develop a global perspective of IBS in terms of clinical practice and research, and I'll come back to that a little bit, to increase the competence, both in terms of clinical practice and research on a cross-cultural level, and to foster the development of multinational research networks. Now, in clinical practice, I think we all are functioning more and more in a multicultural milieu. I know that I myself meet people from various cultural and ethnic backgrounds in the course of my clinical work. And this affects the patient's explanatory models, which we'll be learning about during the course of the meeting, and the patient-physician relationship in ways which we may not be aware of enough. So one of the questions that arises is, do patients have the requisite health literacy, and do doctors have the requisite clinical competence to function in this type of complex environment? In terms of research, there's a growing need for collaboration. There have been initiatives in various parts of the world, and I think one of our objectives will be to try to bring these together in a logical way so that we will be as efficient as possible in conducting multinational research. But then the question arises, do we have sufficient knowledge or experience in the design and implementation of studies of this type? And I think that in this regard, we can learn a lot from our sister disciplines, particularly in the medical anthropology, in the psychiatry field, where a lot of this has developed. And indeed, part of our faculty, for that reason, has been brought from those disciplines. So in a way, we're trying to think out of the box and to get perspectives and insights from an extended faculty, which includes gastroenterologists from around the world, medical anthropologists, psychiatrists, and representatives of various regulatory agencies who will be speaking over the course of the next day and a half. Just an example of some of the points for discussion that we might have. Maybe a primary one, is IBS a universal disorder? In terms of pathogenesis, food and food-related symptoms, all of these issues that appear here are actually going to be focus points of the various sessions that we have in the meeting. In terms of attributions, what are the patient's and the doctor's mind and body attributions to the symptoms and the causes of disease? How are their explanatory models affected by culture, ethnicity, or geographical region? And do doctors, when they weigh treatment management strategies, weigh cultural issues in planning those strategies? How can we improve the methodology and the implementation of multinational drug trials, taking into consideration the various cultural factors and regional differences that we'll be discussing? So quickly, in terms of clinical competence, looking at from the patient perspective to start with, if a patient has a problem with health literacy, it can result in difficulties in understanding things like diagnoses, discharge instructions, or treatment instructions, and then as a result to noncompliance and to poor outcomes. If they do have the skill to function in the system, then it will lead to better health outcomes. The doctors also have to have the competence to function within these systems, so that if a doctor does not have cross-cultural competence in clinical practice, it can lead to clinical misunderstandings relating to things like attitude to authority, how to conduct oneself within the physical space and physical contact, communication styles, sexuality, and the involvement of the family in all stages of clinical care. In terms of research competence, we need culturally appropriate research designs and methods. We need suitable study instruments that have been appropriately translated and validated in study languages. I think one of the important points today is that medical technology has brought us to the point that we can conduct research in the complicated types of setups which in the past we weren't able to do, and that is because of the increased facility of communication through the internet, email, teleconferences, and so on and so forth. So that communication really is instant, and things can be done in a way that we couldn't dream of doing before, and we really should be exploiting these opportunities. So with all of that in mind, and I think this was set for 5 minutes, not for 10 minutes, if I'm not mistaken, but I will anyway. Okay. A few points about our meeting, which I think are important. Eamon mentioned the idea of interaction. Having this meeting as an interactive meeting is particularly important, I think, taking into consideration the nature of the subjects and the issues that we'll be discussing. So one aspect of that will be that we have 2 workshops scheduled for this afternoon, one on cross-cultural clinical competence and the other on cross-cultural research competence. The first will include professional actors and role-playing to simulate various cross-cultural encounters, so to speak. And the second one will be focused on all the issues of cross-cultural research, which I mentioned earlier. We have, I think, in contrast to most meetings, set up more extended question and answer and discussion periods, so that almost every session has a half-hour discussion period at the end instead of the usual 10 minutes or so, in the hope that we can really generate some interactive discussion and stimulating ideas back and forth. And I please ask everybody to utilize that, and so we can make the most of it. Finally, a request to the speakers. We have a really tight schedule to keep to your time. If you don't, we have one of those vaudeville hooks, you know, and we can just, as soon as that goes red, off you go. So just some acknowledgments. It's been really an honor and a pleasure to work with Eamon on this conference. And Doug Drussman has been giving us support right from the start and done tremendous work. There are representatives of both the Rome Foundation, the WGO, and the IFFGD on the planning committee, including Lynn Chang, Max Schmulson, Richard Hunt, who unfortunately was not able to attend the meeting but has sent his greetings and his regards to everybody, Kok Angui and Carolina Olano. And then the support staff from the 2 organizations, which have just, I really don't have words to say, the amount of energy that they've invested in this, the resources that they've brought to it, and the skill and talents, and they've really done a fantastic job, and I hope that we justify their input. So let's have a great meeting. Thank you.